Hey, good morning, and welcome to the UroPatient podcast. I'm your host, Vic Sinise. Welcome to the show. We meet here every Saturday at 10:30 a.m. And if you're watching us live on YouTube or Facebook, glad to have you on board. You can learn more about the show by visiting us at UroPatient.com, the best place to go to learn more about our show. Also, you can find all of our past episodes. Remember, this was created for you, the patient out there. I also created all these helpful handouts. Every time I have an episode, I've got a handout to go along with those episodes. You'll find them helpful. Check them out at any time. They're there for you guys. So I'd like to start off a little history, the evolution of the penile prosthetic devices. And so I was able to, in my research, notice that the earliest documentation of an artificial penis for medical use was the 16th century. And that was a guy by the name of Ambrose Paré. And he's credited, I hope I'm saying that right, I'm not French, is credited with making the first artificial penis from a wooden pipe for a patient to facilitate micturition. So it wasn't actually used for sexual intercourse, but it was the first attempt. And I tried to dig through the internet to try to find a good picture, but this is the best I could come up with. In 1936 and 1948, Borges and Bergman both did some research on using rib cartilage for making the penis rigid. And although I thought it sounded kind of crazy that they would be using rib cartilage, I did some research, and actually there was quite a bit of things being looked at with rib cartilage and breaking it down to use as a matrix to build stuff on. So it was used. They reported satisfactory intercourse results 4 months after the completion of the procedure. However, the issue was it had a super high infection rate, which meant that it didn't last. And unfortunately, the bone material was reabsorbed over time. Now, most of the reports said that because of the infection, there was a lot of almost like Peyronie's curling of the penis and things like that and scarring, which made it useless. But at least there was, some thought going into it back then as to what they could try to do to try to treat erections. I was kind of surprised that it dated back that far. Now, in 1952, Goodwin and Scott reported on 5 cases with an acrylic prosthesis. The advantage was it's not absorbed by the body. The positioning that they did surgically, I don't think made a lot of sense. It was positioned beneath buccal fascia, and they had very few successes with it. But it wasn't until the 1960s that the space program developed siliconized rubber, and silicon rubber was then approved for human implantation. And that really is what spurred on and got the penile prosthesis that we currently utilize. And 2 new silicon prosthetic devices would be introduced. One was an inflatable penile prosthesis, and the other was the malleable prosthesis. And I'll talk a little bit about each of those and how they differ. So in 1967, Pearlman, described placement of a solitary silicon rod, again, between buccal fascia and the tunica albuginea. So right in there. Now, modern prostheses are placed inside the corpora cavernosa. That was it wasn't done until much later. So that's the rod. Actually, this thing right here is the rod that I was able to find a picture of the Perman celastic rod implant. And probably no surprise, it caused significant pain and long-term results were unsatisfactory. But at least we're getting on the right page and something that's not going to dissolve. Now, in 1973, Brant Scott and his Houston colleagues successfully implanted a device using a pump system with saline to achieve an erection. And I've got a picture of what that first design looked like. And, for those that are familiar with penile prosthesis, the modern penile prosthesis, although it's undergone quite a few changes, the basic way it works is still the same. You've got a reservoir that holds the fluid, and then you've got some kind of pump device. In this particular one, they have 2 pumps that pumps the water from the reservoir into these rods that then are able to hydraulically fill with fluid, become firm, and are useful for erections. In 1974, Small and Carrion introduced the implantable silicon rod as a prosthesis. Now, this would be what we consider a malleable, malleable prosthesis, not an inflatable one. So this was placed and then it was hopefully bent out of the way. Now, the only problem was that early prosthesis, the silicon was pretty stiff and didn't really allow for concealment. It wasn't until 1978 when Jonas came up with the malleable implant. And what he did is he put a silver wire inside that could be twisted. And then it would maintain itself so you could bend it out of the way when you didn't want to have an erection and bend it up for use. And the modern penile prosthesis is very similar to that. So it's really kind of withstood the test of time. The DuraPhase, I included this slide for one reason. It's no longer available, and it was kind of an interesting device. So all these little things you see here are like little dishes in a row, and there's a wire running through here. And when you click the device, this wire would shorten and these things would all stiffen and it would make it into a prosthesis that could be used for intercourse. When you were finished, you just bent it like you kind of see here, that bend, and that would release that mechanism. And then these things would almost become like a normal penis, soft. Now, the only reason I included it is we had one of these in our office and I used to just love playing with it, clicking it, unclicking it, clicking it. It was just a fun thing to use. We never implanted any in our practice. Again, they're not available. And the reason they didn't succeed, because it's not a bad idea. All in one, so you only have to implant those two things. You don't have pumps to implant and reservoirs. But they weren't very durable. That mechanism, the mechanics, playing with it back and forth, they break. Eventually, I broke ours too, by the way. In the US, the inflatable penile prosthesis became the most popular player. And I think it makes a lot of sense. It's just the most concealable, most natural looking. And the big major players are AMS, which was actually Boston Scientific bought them out, and Coloplast, which was formerly called Mentor. So two big players left in the penile prosthesis arena. So how does a penile prosthesis work? So as I showed in the early version, it's not much different. There's a reservoir planted somewhere up here in the abdomen. There's a single pump planted down by the scrotum. And then there's connecting tubing to these two cylinders. By pumping it, you can pump fluid out of the reservoir to fill the cylinders. I've got a little film, I think, that shows it better. I like Coloplast marketing, the Titan. Let's get my picture out of the way here. So you can see that's the pump. Patients have to be instructed on how to find the pump, squeeze it. And then as they squeeze the pump, the fluid's coming out of the reservoir. We can see the reservoir up on the top. And it's filling up those cylinders. And it creates a fairly normal looking erection. And then when you're finished, this particular one, you just push the button and it allows the fluid to be compressed back into the reservoir. Some of them, you actually have to hold it. Slight difference in the two. And then it returns back to a normal flaccid state. So complications, probably no big surprise. Uncontrolled bleeding after the surgery, possibly even leading up to a reoperation. The penis is fairly vascular and these rods are placed in through the corporal cavernosa. And you're going into the scrotum with the pump and up in the abdomen with the reservoir. Infections are always a big concern because if it gets infected, it's going to probably need to be removed. I can tell you that early on in my career, I was fortunate enough to get to go in and scrub it on some of those cases with our docs to see how the prosthesis was done. And I've been in, several of the cases in the OR in my early career. And the one thing with penile prosthesis, they consider that like the most sterile technique possible. They would keep anybody out of the room. So once you got in the room, you couldn't go in and out. They wouldn't allow anyone else to come in and out of the room. Nobody circulating. The people in the room stayed in the room because they didn't want dust or anything to get in to try to be a risk for infection. So they were very careful about it. They took it serious. And their success rate was very good because of that. Scar formation, some scar formation we expect. We want that pump to scar down where we can use it, but you can get scars everywhere else. And erosion is one of the more serious things that can happen. Tissue around the implants can break down. And then, like any other mechanical device, they fail. It's just a part of reality. So if they fail, they're rarely repairable. So, and one of the things about penile prosthesis that I always warn patients is, once you pick that option, that's it, because you've pretty much ruined the corporal cavernosum. So a pill that comes along won't work. The injections are not going to work. I have used some vacuum devices. I can talk about that if you want later on patients who had a failed pump that still had the fluid in the reservoir. You could pump it in that way, but the locking mechanism for the fluid wasn't working. But it didn't work very well with them. So let's talk a little bit about post-op instructions. So we always warn patients that there's going to be drainage from the small opening located on your scrotum for probably about 3 days. Wear a pad to absorb this fluid. I always say it's good to let patients know what can happen and what to worry about and what not to worry about, so they're not, getting nervous. Big one, I always tell patients there's going to be a lot of bruising, a lot of swelling, and a lot of discoloration, penis, scrotum, and pelvic area. Just remember how that lymphatic drainage is, so you can imagine where that black and blue is going to go. Some patients will really get freaked out by it, but I think as long as they know it's normal, it's not something, if they're bleeding inside, it's just that's the normal drainage. It helps. As healing occurs, pain will gradually subside. A lot of these guys are pretty miserable right after the surgery. I can tell you that. It's not very comfortable to have all that. And you can imagine all the manipulation that's done to place those rods. So they're pretty sore. And we tell them it's normal to have pain and swelling, especially when standing. We also warn them that there's a certain amount of fluid that we leave in the cylinders at all times. This is to prevent formation of scarring on a completely deflated cylinder. So it's normal to feel a partial erection. What you don't want to do is have it pumped up. Now, when we place the prosthesis, they have a lockout button that is engaged by the physician, so that the pump the cylinders only have so much fluid in them, and you can't pump it. But you can, if you accidentally disengage that, you would be able to. And that's what we normally do on their first visit, is when we have them to teach them how to use it, is we disengage that button. Scar tissue will form around the penile pump. This is probably the most important part of patient teaching. Is it's going to scar, but we want it to scar where they can use it. It's got to be down low in the scrotal sac. Some patients are afraid to touch it, or they don't leave it. We tell them they have to pull this pump down every day, because otherwise it may scar up into the groin, almost like where a hernia would be. And it'll be almost impossible to activate it and deactivate the device. So we tell them gently to retract the pump down in the scrotum every day. And if they just kind of find it, reach up, find it, and pull it down. They're not going to hurt it. Just grab it, pull it down. And again, early on, it's sore, so they tend not to want to do that. Also, it's imperative that the penis be maintained in a straight position. This involves keeping the penis pointed toward the belly button using tight-fitting underwear. So we always instruct them wear the penis up, good solid support, so it stays up like that. On the third day after the procedure, we recommend that they take 2 to 3 20-minute baths a day, no showers, to help prevent that swelling and tenderness. For the first 48 hours, they're generally told to stay in bed. Obviously, you want the dependent drainage. If they're standing, gravity's going to make things drain. It'll swell more down there. So we try to keep them on bed rest to minimize that swelling. It's not strict where they can't go to the bathroom, but it's just to keep them in that position. You should walk for about 15 minutes 3 times a day after that. You want them to be active. You don't want them to just be laying around. Otherwise, you're risking such things as blood clots in the legs. So there's really 2 major players in the prosthesis world for inflatables. And the one is the 3-part, which is shown here. So you've got your reservoir, your pump, and your 2 cylinders. So that's considered a 3-part. There has been some looks at trying to make this easier by putting just one reservoir and pump in one, so that you can pump it up with just having this one scrotal pump and no reservoir implanted elsewhere. I couldn't find a picture of it, but we used to have one that you could actually squeeze the tip right up here. All you did was implant the 2 rods, and the entire thing was right within the rod. So you would squeeze the tip up here, it would pump itself up and get hard, and you would just then kind of like bend it over, and that would release the pumping mechanism, and it would get soft. I thought it was a pretty cool design, but I can tell you that the aesthetically, this was the one that most patients liked the results the best. It was the most natural looking erection, where the other ones don't quite get as much. Most of these prostheses go from soft to hard. Normal erection, you get girth. Some of the newer ones do get a little increase in girth. There are some that actually will increase a little bit in length, and it's not to make the penis bigger, but sometimes it just fills out better. Remember, these corporal cavernosal rods only go up to the tip of the penis. They don't get to the very head of the penis. So sometimes patients notice a little bit of a floppy tip on their erection from that. So some of these are better. Those all-in-ones didn't really do anything more than get hard and soft. So I hope you enjoyed this episode. We'll see everybody next week on UroPatient.com.